proud to say my student, and after that he's done his DM in endocrinology, and now he is pursuing his PhD through CMC Bangalore in Australia. And Dr. Chitra Selvan, who is an endocrinologist and an MRCP as well. She is working in Ramya Medical College and Hospital in Bangalore. So with these two very eminent, young, budding endocrinologist speakers who will give you absolutely the latest, we have this starting an osteoporosis clinic. Please do give us your feedback afterwards on what you thought of the whole thing. Yeah?
Thank you. So, thank you for using lunch hour to learn a little bit about osteoporosis clinic. Dr. Nitin and I have tried to put together a brief overview of an introduction to osteoporosis and how you could start osteoporosis clinic. So let this be an interactive session. Both of us love interaction and questions. It will be much better that way. So we'll quickly go, I'll briefly give you an introduction as to what osteoporosis is. And Dr. Nitin will then take you over the diagnostic tests to detect osteoporosis and the interpretation of those results. And then quickly I will come in to talk a little bit about the different options available. And then Dr. Nitin will take you through some of the pitfalls that are to be anticipated while you have osteoporosis clinic and how you go about it. Okay? So please keep it interactive, stop us wherever you think you should. So the overview, how common is osteoporosis? So this is data from the US, but I'm not very confident that it's any different here. Almost 50% of women over 50 years or 20% of all men will have an osteoporosis related fracture in their lifetime. That is every 1 in 2 women or 1 in 5 men. Okay? And with the population of people who are aging significantly high, we are going to be seeing more and more of osteoporosis. So it's better to be geared up. So what's in the name? What does osteoporosis mean? It literally translates into porous bones. But if you stop and take a look, what makes a building strong? Don't say foundation. That's not the answer. So not only does the strength of the brick and the mortar matter, but also the grits that hold the brick and the mortar also matter. So if you can draw an analogy between that to your bone, not only do we have the bone mineral which makes the bone strong, but also the microarchitecture which holds the bone up also matters. So exactly that concept is incorporated into the definition of osteoporosis. So low bone mass, that is if you have a mineral density which is low, along with microarchitectural disruption. Okay, and I'll show you pictures to let you know what microarchitectural disruption means. Both of these cause weakening of the bones which predispose to fracture. But you're going to have Dr. Nitin coming up to talk about the most commonly used methods for detection of osteoporosis, and you will understand that we are seriously, let's say, falling short of picking up all aspects of osteoporosis. Okay? But remember that the definition does include both the low bone mass and the microarchitectural disruption. If you can go right back to the first year of medical college where we learned about the types of bones, we all know that there is cortical bone and there is cancellous bone. Cancellous bone is also called as trabecular bone. The difference between the two bones is obvious, right? What is obvious between the two pictures? Trabecular bone is more porous, right? There is lesser those trabeculae going between the two ends of the bone, whereas the cortical bone is more tightly packed, right? So naturally speaking, trabecular bone or cancellous bone is weaker than the cortical bone. So if you take a look at all the skeletal bones in your body, the cortical bone is usually the long bones. The trabecular or the cancellous bone is usually present at the ends of the long bones. Okay, so the femur. Okay, also vertebrae. Vertebrae are predominantly trabecular cancellous bones. Okay, so if you take a diagrammatic depiction of what osteoporosis looks like, look at the normal bone and look at the bone which is showing osteoporosis. Could you point out the differences? The thickness of the cortex is much lesser, the osteoporotic bone, but also the density of the trabeculae is also poor, with many gaps in between. Okay, so those are the two distinct changes which happen, which increase your risk of fractures. So the most common areas which are more susceptible to osteoporotic fractures are naturally areas where you have greater trabecular bone or cancellous bone, but also areas which are more susceptible to falls. Right? You don't have a fracture most usually unless there's a fall involved. Okay? So the most common areas of fractures which are related to osteoporosis is the neck of the femur, the vertebrae, and the lower third of the radius, which is called as the Cole's fracture. There's also another odd phenomenon which happens here. The Cole's fracture, the lower 1/3 of radius fracture, occurs mostly in women who are much younger, in their 50s or so, whereas the other two fractures occur a little older. Now, the explanation for it is not very clear, but it's said to be related to the way that we fall, right? Somehow in the 50s, when you fall, you're more likely to use your hand outstretched, and a fall on your outstretched hand is what results in a fracture of the lower third of radius. But that's just digressing. Let's go back to, so what if you have a fracture? Many of my patients ask when they come in with a fracture neck of femur, so what? Why are you coming and talking to me about these things? So people who've had one fracture have a very high risk of a second fracture. Alright? So there's a 20% risk of a second fracture. But hip fractures are more dangerous than vertebral fractures, simply because not only does it put you at risk for future fractures, there's a sharp increase in mortality with hip fractures. Close to 1/3 of individuals who have a hip fracture do not ever regain their functional abilities after the fracture. Up to 30 to 40% of them tend to be bedridden, and we all know that the minute your patient is bedridden, the chances of having any other complications like a DVT or a bed sore or an infection go steeply high. Okay, so we should not wait for a patient to have a first fracture to prevent the second fracture. We should, at the end of this hour, know how to detect and stop even the first fracture. Would you want to stop and pause at this sentence? It might not be pediatric per se, but I like it because it rhymes. Geriatric with pediatric. What do you think it means? Please say anything, ma'am. The foundations? The foundations, yes. So what happens during your adolescence and maybe your early adulthood is what is going to determine how it is going to pan out in the future. So this is a graph which is a graphical representation of the bone mass. Okay, the pink is for women and the blue is for men. Okay, notice that the bone mass, bone accrual increase occurs through childhood. There is a peak at around puberty, but the maximum bone mass is attained at around 25 years. Notice that at 25 years itself, the men are having greater bone mass than the women. Okay, and then notice that both in men and women that there is a gradual loss in bone mass after 25 years, right? And notice at about 50 years what happens to women? There's a sharp drop in bone mass, okay? And then even after that it continuously drops. The men who started out higher, who are continuing to lose bone mass, also reach a critical mass of bone mass slightly later than men, slightly later than women, but their bone mass also comes down. So the points to take away here is if you start out with greater bone mass, you're less likely to have a lesser bone mass at the end of your 50 years of age. Okay, so making sure that our children get adequate calcium, vitamin during the time that they're accruing their bone mass is crucial. Men also have osteoporosis. Women have a slightly accelerated drop in bone mass at around menopause. So the age of menopause is important. It also highlights the relevance of sex steroids or gonadal steroids to bone health. Okay? So if you're thinking about why we're getting osteogenesis fracture, the most important contributor or determinant of osteoporosis factor is genetics. How strong your bone is primarily 80 to 90% determined by your genetics. You and I can only alter 10% of it. So the simple way to find out if your patient is at risk or not is to ask if there's a family history. If a mother or a grandmother or her sister has had a fracture, your patient is at risk. Okay? But apart from that, there are a few other factors which can contribute. Like we said, hypogonadism, which is onset of lack of or less of gonadal steroids being present is one of the risk factors. Any other risk factors you can think of which can accelerate osteoporosis? Can you think of any drugs? Commonly used steroids. Pioglitazone. We hold pioglitazone for now, but steroids, okay? One of the biggest risk factors for osteoporosis. So if you have a patient who's used steroids for at least 3 months, very high risk for osteoporosis, okay? Please mark that patient, okay? Of course, there are some other factors. If you have a disease which increases the bone turnover or weakens your bone, can you tell me a couple of diseases? Thyrotoxicosis, very good. Yes, sir. Hematological malignancies. Myelomas, very good. Cytotoxic drugs, very good. Okay, so everybody's on the case. So we know that there are many factors which can alter the bone turnover rates. So if you have a patient who's taking steroids for RA, you should mark them as a star, okay, and watch out. And all of these leads to increased bone loss, but you should also be assessing propensity for falls, because falls are invariably related to at the end result is a fracture. So that's the list of diseases, but I think we've covered most of it. Rheumatological illnesses is one, steroid use is one, okay. So go through the list and pick your favorite. It pretty much includes everything, every coexisting comorbid condition that you can think of. But the relevant ones should be hyperthyroidism, premature menopause, or oophorectomies, which are also very common conditions, steroid use of certain drugs, okay, which can all increase your proton pump inhibitors. Do you think they're associated with osteoporosis? Yes. There is evidence now to say that chronic use of proton pump inhibitors itself can worsen osteoporosis, okay? So just to summarize the risk factors, most of it is genetics, but age is one, age of onset of menopause is one, low BMI is one. Remember that it affects men as well. Some others are low estrogen, testosterone. Some rarer diseases like hyperparathyroidism. Parathyroid is a hormone which breaks the bone to make sure your calcium levels are normal in the blood. Think about that. We'll come back. I've listed hyperparathyroidism as a cause for osteoporosis. Steroid use is one of it. Proton pump inhibitors is one of it. So clinically, the problem with osteoporosis is that it's asymptomatic, very much like diabetes, unless there is a crash, right? So most of them are asymptomatic for the longest time, but back pain, if they're complaining of chronic back pain and if they're slightly hunched, then you should look for vertebral fractures. And of course, they can present with a low impact fracture. What is a low impact fracture? You're climbed up to the 3rd floor, you miss a step and you fall down 3 floors. Is that low impact fracture? You have to break bones from that fall, right? But you're walking here and you trip on the carpet and you fall down and you break your bone. That would be a low impact fracture, right? So there is a difference between the two, okay? So if you fracture on trivial trauma, on a low impact fracture from a fall which is the same as your height, that would roughly qualify to be a low impact fracture. Loss of height. We've all seen our older women. There are lesser older women who are all hunched, but if there is a loss of height, if you feel your granny is looking shorter than before, what should you do? Dr. Nitin will tell us next, but at least you should get a X-ray, lateral X-ray of the vertebrae. Alright. So quickly to summarize, it's extremely common, it's asymptomatic, with more and more of our patients living longer, which is a good thing. This is going to be a thing which is going to be in our face. Fractures seriously bring down quality of life, also increase mortality. Post-menopause, we all know the risk factors. Encourage our children to increase the peak bone mass generation. I'm going to call Dr. Nitin to take us through, now that we know osteoporosis is a thing, how do we detect it? Truly overshooting our time limits. So I'm quickly going to go through therapeutic options. I'm going to leave...
We would request you to continue.
Okay, so, okay, so can we do it leisurely? Since this room is ours, nobody's going to take this room away. Okay, fine. So then we can do it calmly. So, I'm going to leave out the sections that Dr. Nitin has referred to so that we don't have duplication and so we have time to focus on what's new. So who needs treatment? I think we are fairly clear that patients who qualify for treatment for osteoporosis will be patients who've already had a fracture at the spine or the hip, and patients who have osteoporosis as per the WHO classification after a DEXA scan, or the third question, ma'am, which you asked, for patients who had T-score between not qualifying as osteoporosis but whose FRAC score was high, right? This is all, you've taken a snapshot of this already. Okay, so those are the people who need treatment. Okay, we are clear on this? Okay, fine. So secondary causes, Dr. Nitin is going to take us through. We've already spoken about the most common causes of secondary causes of osteoporosis. It's important to do a cursory search for it at least, so that if we target treatment towards that, the outcomes of osteoporosis treatment will also improve. So if you are going to do a low resource set of tests to rule out secondary causes of osteoporosis before you start treatment, it should be targeting these conditions, and it should involve those tests at least to start with. Okay, so we're doing a hemogram and ESR to rule out the rare chance of multiple myeloma being the cause for the vertebral fracture. We're doing a TSH to rule out hypothyroidism. Renal failure is a common cause of poor bone health. We have to make sure calcium levels are normal before we start your patient on bisphosphonate therapy. So that's why we're doing calcium, albumin and phosphorus. Also, the calcium will also help you catch the hyperparathyroidism. PTH regularly, routinely not recommended if your calcium level is normal. If your calcium level is in the higher range, only then you do a PTH. PTH is an expensive test, number one. PTH is also a very finicky test. Finicky meaning it is, you have to maintain a cold chain and make sure it is assayed within 20 minutes. You have to use a cold centrifuge. Even in the best of settings, it's very difficult to get an accurate PTH reading. So most times PTH is an overused tool where you don't truly get correct information. Do a calcium if you're screening for hyperparathyroidism. If your calcium is high, considering the vitamin D deficiency that we are on, and if you've ruled out vitamin D overcorrection in that patient, and if the calcium is high, then the most likely cause, then you are justified in doing the PTH. Regularly in the screening of osteoporosis, I would say no. Would you agree?
Yeah.
Alright. So if you've decided to treat, there are some universal recommendations which go for all patients with osteoporosis, and that's just it. Counsel to them about the risk, because most people don't understand what you have understood from the DEXA scan, right? You might be talking about osteoporosis and osteopenia. Tell them that they are at risk for fractures. Calcium and vitamin D is very, very important. Not right after the fracture, but at least when your patient has not had a fracture or has recovered from a fracture. Speak about incremental physical activity. I don't have a slide on it, but focusing on weight bearing exercises and also strengthening and balancing exercises with the motive of bringing down their falling risk. Okay, and then smoking cessation and alcohol use. I will touch upon all of them. So calcium and vitamin D. Okay, overall, Indians have a very low calcium intake if you're only relying on your diet for calcium. There are numerous surveys, most of which are putting our daily intake at around 400 milligrams to 500 milligrams per day, whereas the recommendation is definitely in 1000 milligrams. Okay.
This is elemental calcium.
Yeah, this is elemental calcium. The next slide is about how to get a brief overview assessment of your patient's calcium intake. And I think vitamin D we are all now very well aware, and we are all replacing well. The only thing that you need to maybe take care of is to check if there is an orthopedician behind your patient who's been giving arachidol injections frequently, because vitamin D toxicity is truly not such a rare thing anymore. So before you prescribe vitamin D, just ask them. Your patients are very smart. They will tell you, have you taken that weekly medication? They will be able to tell you if you're on it. Alright? Okay. So please note the numbers, 1000 to 1200 milligrams. Okay? So now, the calcium intake assessment. Simple question. Do you drink milk? Do you eat curd? That's a good question. A 200 ml glass of milk is roughly equal to 300 milligrams of elemental calcium. Okay? A serving or a katori of yogurt is roughly equal to 300 milligrams of calcium. From our everyday food, which is ragi, chapati, vegetables and all of it, you get another 300 milligrams. Okay? So, if your patient does not drink any milk at all, his calcium intake is 300 milligrams per day. If he is drinking 1 glass of milk, it is around 600 milligrams per day. 2 glasses of milk coming up to 300 milligrams. 2 glasses of milk, normal food, 1 katori curd coming to around 1200. That's all. It's very simple. So only one sentence to assess calcium intake. Do you drink milk? Do you eat curd? That's all. If they are taking a calcium tablet with a strength of 500 milligram, roughly works out to an elemental calcium of 300 milligrams. Okay, that's all. Is very simple. Okay, don't break your head with that complicated table. But nobody drinks 200 ml of milk actually. Most women tend to do small shots of milk, and they tend to always have coffee or tea with it. Okay, so Dr. Nitin did speak about risk. When he presented data on the survey that they did of the South Indian women who had fractures, they identified a few factors, right? So visual impairment, sedative use, and what was the other component, Dr. Nitin?
Yeah, sedative use, rheumatoid arthritis.
Yeah, those were the risk factors which they identified. So please ask a question about assess your patient's risk of fall. So if your patient is having neuropathy and is not able to walk too carefully, it's a risk. If your patient is having proximal myopathy due to some other reason, then that's a risk of fall. There could be other environmental factors, right? If the way to the bathroom in the middle of the night is not lit properly, if there's a loose rug, right? All of those are factors which can increase. So a few cursory questions asking about your overall patient's risk of fall, his house, the lighting, all of that, and one or two changes, right? Can go a huge way in reducing the risk of falls in your patient. Okay, so now that we've done the overall universal recommendations, we'll now go straight out to the therapies of osteoporosis. Broadly, therapy for osteoporosis is broken down into two headings, okay? One is anti-resorptive therapy and the other is anabolic therapy. Anti-resorptive therapy is where you just make sure that the bone is not being resorbed anymore. You do something to slow down the rate of resorption. Whereas anabolic therapy is where you actually focus on forming new bone, increasing your bone mineral density. Okay? Broadly under these two categories will be bisphosphonates under anti-resorptive therapy and teriparatide under anabolic therapy. All the others are, they take secondary positions. Okay? So that brings us to this question. I think we understood this question. Bone is not just a scaffold inert thing. It is a very living organ which is very active, probably one of the most active organs. And you remember that picture from Dr. Nitin's presentation where there is a CMC building. Even Ramaya building seems to be going through this. But let's break and let's build, let's break and let's build. So it's a common thing with the bone as well. Okay, but like he said, there is no new formation without resorption, right? It's a very, very key thing to understand. So if you are going to block resorption, you are in some way blocking the bone formation as well. So remember that sentence when we come back to talk about the side effects of bisphosphonates, okay? So bone remodeling is a constant process. It's very closely regulated when you are younger, meaning whatever bone you resorb, same amount of bone is formed when you are young, okay? But after menopause, whatever bone is resorbed, the bone formation kind of slows down, it's not able to match up. And that's why you're losing bone mineral density with time and right after menopause. And this bone remodeling is more active in trabecular bone. Okay, so we just have to learn a little bit about the cells. Are you willing to, yeah? Alright. So this is the osteoblast. Okay, osteoblast is the active cell of the bone. Okay, and this red thing is the osteoclast. So the osteoclast mediates bone resorption. So your bisphosphonates, which are anti-resorptive, should target osteoclasts. And the osteoblasts are the one which enable bone formation. Osteoclasts do not have a way of communicating, or we don't have a way of communicating to osteoclast by itself. All the communication goes through the osteoblasts. Okay? So if you notice here, the black thing is the rank ligand. The osteoblast sends out a signal called the rank ligand, which goes and gets attached to the osteoclast progenitor, called as the rank receptor, which then helps in maturation of the hematopoietic stem cell to produce a fully mature osteoclast, which then goes to go and resorb the bone. So the osteoblast is actually sending the signal out to the osteoclast. Please remember that rank ligand, will come back to that. Okay? Fine. We spoke about this. Alright. So if you see here, this is the osteoclast, okay, which is eating away the bone, okay. Then those are the osteoblasts which are active. This is the the matrix which is being laid down by the osteoblast, which then gets calcified. Okay, so that's the whole process of how resorption and formation occur together. Okay, fine. Now we're coming to bisphosphonates. This is the bisphosphonate, and that is the pyrophosphate. The bone mineral is of two minerals, right? Calcium along with phosphate, right? Notice the similarity of the structure of bisphosphonate with pyrophosphate, okay? So when you administer bisphosphonate to anybody, it gets incorporated into the bone, simply because it looks very much like the phosphate, yes? But bisphosphonate has additional action apart from being incorporated into the bone. It by itself can cause the osteoclast to undergo death, right? Which means you're cutting down the number of osteoclasts. It also inhibits a whole lot of steps which are required to form bone resorption or to cause bone resorption. So it leads to osteoclast death. So that's how you bring down bone resorption. There are many bisphosphonates, I'm sure you're all aware of most of them. Zoledronic acid is the IV form of bisphosphonate. All the others are orally administered. Some are administered weekly, some are administered monthly. And to answer your question on glucocorticoid-induced osteoporosis and postmenopausal osteoporosis, pretty much all of them are approved for use in both of these conditions. And when you talk about their efficacy, the relative risk reduction of vertebral fractures and hip fractures for most of these agents are to the tune of 40 to 60% relative risk reduction of fractures itself at both vertebrae and at hip. We spoke about monitoring of response to bisphosphonates with either the bone resorption markers. Dr. Nitin has highlighted that we do not do a DEXA scan up to 2 years after starting treatment. But with bisphosphonates, you should be aware that the fracture risk, or with any treatment for that matter, the fracture risk is not completely eliminated. You're reducing the risk, but it's not completely eliminated. The oral forms of bisphosphonates have very poor bioavailability, right? Only 1% of it is truly absorbed, and they're very irritant to your esophagus. So if you remember that paragraph from Harrison, tell me all the things that you need to do if you take oral bisphosphonates. Fasting in the morning, sit upright, how many glasses of water? Lots. 2 to 3 glasses of water with the intention of pushing the tablet into your stomach so that it doesn't stay somewhere in the esophagus, because there are instances of where it can cause esophageal ulceration if it gets retained in your stomach. And sit upright for about 30 minutes, preferably an hour, and in a fasting state, okay? So honestly speaking, there are some patients who would not even go to the second tablet. Some patients, very few patients tend to do very properly all these instructions and like the routine of taking oral bisphosphonates, okay? All the bisphosphonates, oral and IV, but IV more than oral, can cause worsening of your EGFR, so something that you must keep in mind. IV, some side effects like atrial fibrillation. Most bisphosphonate use, especially IV, can cause a fever-like thing which happens, which is easily treated with paracetamol, but it's important to tell your patient about it, right? We've had a few patients who've had delirium and gotten admitted in the hospital and all of that. Okay, what is this? Yes. So this was a patient who was getting bisphosphonates, but she was getting it for a malignancy, and in malignancy they usually give huge doses very frequently, right? And she presented with this wound at the jaw, which was not healing at all, okay? What do you think is the connection between bisphosphonates and this jaw? It's the bone, right? Yeah, it's the bone, right? So if your patient who's on bisphosphonates comes with persistent toothache, jaw complaint, something which you're not able to understand, make the connection between the two, okay? So it's very rare. It doesn't usually occur when you use bisphosphonates in the dose that we use to treat osteoporosis, but it's very common, especially when patients are getting bisphosphonates along with other treatment for malignancy per se. Just like how we are going to talk about atypical fracture treatment with teriparatide, there's also some role for teriparatide in the management of this. Teriparatide is the anabolic therapy. Dr. Nitin did show us this thing about subtrochanteric fractures. So if it's an osteoporotic fracture, where is the location of the fracture in the femur? neck of femur, right? So the location is subtrochanteric here. Okay, so this is again similar to the picture which Dr. Nitin showed. Is the cortex thin or thick? It's thick, right? So that's one important feature. And if this is an osteoporotic bone, right? The cortex is thin here, right? If I go back to the previous picture, the cortex is thick here. And also there are some other variations like the pattern of the fracture is spiral if it's osteoporotic, whereas it is transverse or short if it is atypical subtrochanteric. But the gist of the story is, if your patient who's on bisphosphonate complains of persistent pain in the leg or the thigh, please think of an atypical fracture and get an X-ray. Second thing is, in about 50% of patients, this atypical fracture can be bilateral. So when you're X-raying, X-ray both the legs. Alright? Okay. There is some evidence to suggest that bisphosphonates can bring down all-cause mortality. There is also some evidence to suggest that it can bring down incidence of breast cancer and all of it. But in this context, we are only talking about how it brings down risk of fracture. Now, if you start your patient on bisphosphonate, does that mean they stay on it forever? No, because we are worried about these atypical fractures, we are worried about osteonecrosis of the jaw. So how are you going to decide which patient stops and which patient stays on treatment? Okay. So there is no guideline or rule which is set in stone, but roughly at the end of 3 to 5 months, pause and reassess your patient's risk for fracture. So up to 3 years to 5 years you can treat your patient, and then at the end of it you pause and take a look at your patient's fracture risk. If your patient's fracture risk is high or in the follow-up DEXA the BMD is still falling, you're justified in continuing bisphosphonate therapy or maybe adding some other therapy. If your patient's fracture risk is low and then you're worried about, then you can give your patient what is called as a drug holiday. Take them off the bisphosphonate for a few years and then reassess the risk. Okay? So do you remember that rank ligand? Yeah, what was it doing? It was communicating to the osteoclast, right? Okay. So this new molecule which is available in the market is an antibody against the rank ligand. It's an antibody against the rank ligand. So it blocks the conversation between the osteoblast and the osteoclast, which means it's blocking the signal for bone formation, bone resorption. Okay. So this agent is called as denosumab. It's available as an injection which is given once every 6 months. It has a similar efficacy as bisphosphonates. I'm sorry about that. Okay. The purported advantage of denosumab over bisphosphonate is that it can be used in EGFRs which are slightly lesser than bisphosphonates. One of the problems you have with bisphosphonates is if your patient has diabetes and CKD, hypertension and CKD, you can't use bisphosphonates freely. This is a slightly better advantage over that. Okay, so that was about bisphosphonates. I know there are lots of questions, we'll take it at the end, but we'll just skip over to the other side and talk about anabolic agents, that is agents which help in bone formation. Okay, the one FDA approved agent is teriparatide. It works by increasing the osteoblast number. But we just spoke about how hyperparathyroidism is a risk factor, right? Teriparatide is nothing but an analog of the parathyroid hormone. So how is it you can think that parathormone can cause fractures and osteoporosis, and also in the same breath talk about using an analog of the parathormone for treatment of osteoporosis? Any thoughts? Calcitonin?
No, unless the parathyroid comes in a pulsatile fashion.
Very good, ma'am, you're bang on point. Okay, sure. Okay. So, if you administer parathormone continuously, if there's continuous exposure of parathormone to the bone, it results in bone resorption. Okay, so this is the normal function where it does increase bone resorption. But if you intermittently administer parathormone, it has an effect both on bone formation as well as bone resorption. But if you intermittently administer parathormone, it has a greater effect on the bone formation than the bone resorption. Should I say that again? If you give parathormone continuously, like a subcutaneous infusion, you are more likely to have more bone resorption. But if you give it intermittently, once in 24 hours, it has a greater effect on the bone formation rather than bone resorption. So that is what we are exploiting when we are giving parathormone injection subcutaneously to treat osteoporosis. And that effect lasts for a finite window. That window is called as the anabolic window. How long is that?
2 years.
12 months to 18 months traditionally, can go up to 24 months in some patients. So if you're using teriparatide therapy, you would get maximum benefits if you use it for 12 to 18 months. If you use it beyond that, you might not be getting as much benefit for bone formation. Okay, is that clear? Is that paradox? Alright, so this is a reconstructed micro QCT image of bones before treatment and after about 20 months of treatment with teriparatide. Are you able to appreciate the difference? Can you tell me what the difference is? Yeah, the trabeculae have become thicker. The trabeculae are seeming to connect from this end of the cortex to that end of the cortex. The cortex is also marginally thickened, right? So those are anabolic effects, right? So we've actually made an improvement not only in the density, which we assess with DEXA, but the CT here is able to assess that even the microarchitecture is improved, right? So which translates into, we spoke about this, teriparatide is administered as a subcutaneous injection, 20 microgram per day, every day, okay? It comes in preloaded syringes, very much like insulin, with a fracture reduction to the tune of 65% of new vertebral fractures, and non-vertebral fragility factors also coming down significantly. So it's more efficacious than bisphosphonates because it's working also on building bone. The side effects that you need to watch out for is hypercalcemia, but it's usually transient, occurs about 6 hours after your injection, because that's also one of the things that parathormone does, right? Increases the levels of calcium. Some concerns of bone malignancies in animal studies, but there's not too much of evidence to suggest that scare in human beings. Some worsening of hyperuricemia and gout. So you started teriparatide, you put your patient on it for 18 months, then your patient asks me, what after that? You're not going to continue, right? You're going to stop it. So ideally what we should do is probably give anabolic therapy for the first 1.5 years, and once there's an improvement in bone formation, stop the teriparatide and give them bisphosphonate to make sure that whatever consolidation we've done, we stop the resorption and slow down the process. So that is called a sequential therapy. So there are trials who have evaluated that. People who got only bisphosphonates, people who got only teriparatide, people who got teriparatide and bisphosphonates together, people who got teriparatide first followed by bisphosphonates, people who got teriparatide followed by bisphosphonates seem to do the best. Okay, so it's best to do a sequence of bone formation followed by prevention of bone resorption. So quickly to summarize all the therapeutic options for osteoporosis, the universal recommendations for treatment of osteoporosis stay: calcium, vitamin D, fall prevention, exercise, quit smoking, cut down excess alcohol, sedative use, all of that. When you're choosing treatment, we have two major options available: anti-resorptive therapy in the form of bisphosphonates and denosumab, and anabolic therapy in the form of teriparatide injections. There are side effects for both of them, but bisphosphonates have a greater oral GI side effects. There's also some exacerbation, also some reports of uveitis being exacerbated with bisphosphonate use. Drug holiday to be considered at the end of 3 to 5 years in patients who have low risk. Atypical fractures and osteonecrosis of the jaw are also rare side effects which occur at high doses. Teriparatide can actually cause an increase in BMD with a significant fracture risk reduction. Sequential therapy seems to be the most physiologically logical treatment option available. I've only managed to give an overview without confusing. There might be many things I've left out. I'll hand over to Dr. Nitin to take.
I have one question.
Yes, sir, sure. Yes.
What is the role of vitamin K27?
K27, I don't know, so Dr. Nitin, any? So there is one company who's mixed calcium with vitamin K, saying that it increases absorption. I'm not really sure that there's any evidence to that. I don't, vitamin D, I don't. Okay, so I will respond that. I will respond. So this thing about calcium supplements and atherosclerotic risk, I will tell you, let me clarify that point because it's, so in populations who are already getting adequate calcium in their diet, either from natural sources, dairy products, or fortified, like in most of the other countries, food is fortified with calcium and vitamin D. In those populations, use of calcium supplements was known to increase one calcification of the vessels, and also one study has reported increase in cardiovascular events. But all of that data might not be exactly applicable to us because we are still a population who are still not eating enough calcium in our diet. Now, if your patient asks you, can I not take the calcium tablet, can I instead drink milk? So that question is also answered, which says that dietary supplementation of calcium is any day better than a calcium supplement. But if your patient is lactose intolerant, please go ahead and ask them to take that calcium tablet. Vitamin K is not known to decrease the calcification of blood vessels. There is no evidence for that statement to be true. Yes, ma'am?
See, how do you decide whether to use bisphosphonates or terephthalate?
That is a golden question. It is the answer to that question is not straightforward, okay? But if you have a younger patient with a longer life expectation, who's able to afford and be willing for teriparatide, the ideal thing to do is start with teriparatide followed with bisphosphonates. There's also a school of thought which says that more severe the osteoporosis, go all out and start with teriparatide and followed with bisphosphonates. But most times this decision is made not based purely on science, but by other factors as well.
The site of fracture also is accounts.
Vertebral fractures are categorized as severe fractures, thereby qualifying more for teriparatide therapy. But ideally you should be doing that, but most times very few patients accept teriparatide. If you offer the option of teriparatide to 10 patients, at least my conversion rate is only 1 or 2 patients agree to stay on it, right? So
most of the postmenopausal females
yes, sir.
are advised vitamin D and calcium combination
Correct.
by general practitioners, gynecologists, all specialists.
Correct.
What is your opinion?
So all of us are vitamin D deficient. So yes, repletion of vitamin D is required. Of course, calcium also we are all poor, so I don't think there's anything wrong in that. One other thing which is generally practiced is using calcitriol for as a vitamin D supplement. That is a strict no-no. You should be giving 25-hydroxy vitamin D along with calcium. So if you, first I would suggest that they increase their dietary calcium. If they are not able to for any reason, then calcium supplement is okay. Ma'am.
Ma'am, as you said, convincing people for teriparatide for a very long time is very difficult. So if people are convinced to use it only for 6 months,
Yeah.
then post that should we start them on bisphosphonates?
Yeah, it would be better than nothing.
Yeah.
I have any evidence for
The
it.
saying was that teriparatide you cannot use it again in the life. So I mean that fear was there when the drug was introduced. That you can use it only once, so don't give it to young people.
No, you can.
Because the antibodies are developed, that is the...
So antibodies to
malignancy. That's what they are saying.
So it might not be so much about don't use it again versus
use it
continuously forever. It must be that. So if you use, if the question is, so right now I have money, I take teriparatide for 6 months, then I'll go off it, I'll use bisphosphonates, and then I want to restart teriparatide again after 6 months. Probably the bone formation at the end of it all will be slightly lesser than if you use teriparatide continuously for 1.5 years. But
yeah, I mean the safety data is not there, and that's
Yeah,
why 18 months is the cap.
Yeah.
It's not
At
that
40 if
we
you
don't know.
use, then you cannot use it at 70. That's what they are trying to say.
Probably we need
by
more
that time we
evidence.
generate that data, but for now we don't have that data yet.
Now there is no
Past,
Yes, ma'am.
past history of renal stones and the patients or doctors say no to calcium supplementation later on.
So, if your dietary calcium crosses 1500 milligrams per day, then your risk of renal stones is documented to be increased in some events. But the most common cause for renal stone would be some independent cause like a hyperoxalaturia or hypercalciuria, which might not be affected by the dietary calcium that you give. In fact, for oxalaturia, low calcium diet increases the risk of renal stones.
But for that, the calcium citrate malate is the best molecule, no? It doesn't precipitate in the kidney.
Okay, so that could be a treatment if you've actually documented hypocitraturia. But if you've not documented it, also maybe the increased citrate increase might bring down your risk.
Why we do not combine calcitriol?
So calcitriol is the active form of vitamin D, which means in your body there's a normal check. Even if you take too much of 25-hydroxy vitamin D, the fact that 1-alpha hydroxylase is actually required to convert the 25-hydroxy vitamin D to 125 protects you from hypercalcemia. When you are bypassing that and giving the active form along with the calcium supplement, and if he's already getting 25-hydroxy vitamin D from many other sources, hypercalcemia can occur very fast.
And the half-life of calcium is very less.
How long we should use
So,
vitamin D?
Yeah, how will that affect?
So it won't work for, I mean, you need good vitamin D for a long term. You cannot be taking 4 tablets a day.
And calcitrol, the risk of hypercalcemia is there.
It's more.
Yeah.
And the vitamin D, the native vitamin D has a half-life you can give once a month or once a... Calcitrol will work for 3 hours or 4 hours. So what will be the effect on the bone?
It is useless.
In this situation?
Yes.
Whether we should give lifelong or...
Yes, ma'am. Vitamin D every week for 8 weeks, followed by every month to continue. Because if you don't do that continuation every month, your vitamin D will begin to dip again. And then the therapy that we are giving for osteoporosis will not be as efficacious. Yes, sir.
Actually, 1 month for 1 year we can handle.
So, I understood the point. Maybe you should go to so you can give because it does not increase the risk significantly. I can't confidently say it will cause AF or it will worsen AF. I can't say that. So you can increase the risk. Yes, sir.
All the diabetic patients are advised vitamin D.
Correct. So diabetic, non-diabetic, everybody is deficient in vitamin D.
The prevalence of vitamin D deficiency is 70%.